This is Shoshana Zetz from the California Institute for Mental Health. You are on the Small County Fiscal TA webinar. Mike's going to take you through some of the financial issues that are facing the small counties in a few minutes. But just a couple of things. As usual, you're all muted currently, but Mike will be pausing on a regular basis to ask questions. So if you'd like to ask a question, you can do so by either typing it into the question box or clicking the hand icon next to your name, and that will alert us to take you off mute so that you can ask your question. You should have all received materials via email this morning, but if you didn't, send me an email or chat and let me know, and I'll send it to you. There was only one document today. And we're recording this webinar. We'll post it on the website probably by next week. There will be no fiscal TA webinar in January, but Mike is planning a budget training on February 5th. We'll get you more information about that soon. All right. So, Mike, are you ready?
Yeah. So what we're going to cover today is what was discussed at the December 5th Financial Services Committee meeting. You can see there the different areas and topics that we covered. And so starting off with this new billing feasibility system study, or short DOIL 3 as some folks have referred to it. Hopefully, as you're aware, CMHDA is funding this feasibility system for a new Medi-Cal, especially mental health reimbursement system. The purpose is to replace the existing short DOIL system with something new. DHCS has said that they cannot basically maintain the existing short DOIL system, and so they want to come up with something different and new. And the feasibility study is the way that the state goes about doing information technology projects. Cal MHSA is managing the process, and you can see the contact person there, Sarah Brickler. And so to date, they've invoiced counties for each county's share of the funding, and I believe they have sent out two invoices with hopefully the same amount. One went out in August, and for those counties that hadn't responded, another one went out recently in November. And those invoices went to the mental health director. So if you haven't seen an invoice from Cal Mesa regarding this feasibility system study, you should email Sarah and ask her for a copy of the invoice. Sarah reported that to date, about a third of the counties have actually responded with funding. Another third have indicated that they are in process of going through the local process to get approval to give Cal Mesa the funds, and then they haven't heard from about a third of the counties, and Sarah was following up with them. Cal Mesa also will assist with the procurement as well as is hosting calls for county questions. And so again, if you want to stay up to date with what's going on with this, I would email Sarah and ask to get on the distribution list. One thing that has changed a little bit since 2 months ago when we talked about this is that we are now looking at more of a short-term and a long-term sort of strategy where the focus isn't solely on the automation, but also looking at how best to define and develop reimbursement policy. And so there's going to be a little bit, especially I think in the short term, focus on defining the reimbursement policies that we should have in the short DOIL system, or should say the Medi-Cal, especially mental health system, and then look at the longer term, how to automate that. And so as kind of a result of that, the short DOIL 2 system, the current system, will probably be in place for at least a year, if not longer. And so just have to continue to deal with the short dwell system with hopefully some hope on the horizon. One thing that has come up is this whole Medicaid Information Technology Architecture, or MITA, which is a process and structure that CMS, the federal government, requires states to do in terms of an assessment when looking at their Medicaid system. And we found out as part of this process that the state has done an initial assessment, and now it sounds like the state is interested in getting the counties and CMHDA involved in the process with the behavioral health, future behavioral health system. So there's going to be a presentation, I believe, by DHCS to the Governance Committee next week on December 19th. Really, in part of this MITA, some of the, just real briefly, a couple of the key concepts. One is that you don't end up with a standalone behavioral health system for the Medicaid program, which is currently what we have. We do have a, the short dwell system is a standalone system. So CMS definitely wants to get away from that, or wants the state to get away from that, and look at a more integrated, interoperable system for all Medicaid services. So we're hoping that will come out of this this feasibility study. The other part of that is that it tends to be more encounter-based reporting, and that really we can start to hopefully differentiate the data reporting from the actual interim payments made based on claims, so that again we start to separate reimbursement from the actual submission of the encounter-based data. Another part of MITA that is I think one of the critical components is that because you end up with this kind of standardized system, you end up being able to purchase more of just an off-the-shelf sort of claims processing system, rather than having to get into all the customization that we have to have in our system, because we have service functions and minutes of service and all those sorts of things. So that hopefully in the future it will be much easier to actually put in place information systems in the behavioral health arena. So if you're a county who is considering changing information systems or claims processing systems at this point, I don't know if I would go ahead very rapidly. I'd probably want to wait and see what comes out of this whole process, and before making an investment in a new system. So lots of stuff still going on. Again, we've got a presentation next week, and not sure on the timing in terms of when a new system will be in place, or when even we would be changing reimbursement systems. But I think it's pretty hopeful that we will start to see some changes and hopefully some simplification, both in terms of the reimbursement policies and the reimbursement system. So any questions on any of that? Again, a lot more to come. Okay. We then went into the short dwell 2 update, and we've been talking about this other health coverage denials, the OCHF denials for the Medicare risk HMOs. We found out that DHCS is real close to putting out an information notice to inform you on how to handle these services, and this is where basically the Medicare risk HMO does not even cover the service, and you're not able to get back a denial from the HMO. You just get a letter. This would allow the HMO to submit a letter to DHCS saying they don't cover the services. And the one positive thing that we heard was that DHCS will accept one letter for all counties encompassed by a given risk-based HMO, so that not each individual county had to get a separate letter from all of the different HMOs throughout the state. So that that was a positive thing. But again, we'll wait to see what the information notice says, hopefully here, within the next month or so. In terms of KDA implementation, DHCS mentioned that they are posting a report on the services that are being provided to this subclass. Although I have to be honest with you, I looked all over their website and could not find it. I know initially CMHDA posted a report that the DHCS provided to CMHDA, but I was not able to see any subsequent reports. They did say they are obtaining input from all the stakeholders, from the attorneys that filed the lawsuit, or the parties that filed the lawsuit, as well as counties, in terms of the content of the report. So again, we'll probably have monthly updates on these reports. And then we talked a little bit about county contract rates. Again, what I think was good news. So if you remember, the DHCS came forward probably about 5 or 6 months ago saying that they were concerned about data entry errors with your rates in your claims processing system. So they wanted to create what they called a backstop, so that if there was a data entry error, that the overstated amount wouldn't get billed. And they had proposed a couple of different things, and we had said a couple of different things. But the bottom line is that DHCS just said it's too difficult to implement, and so they're not going to move forward with a system edit to put in place a backstop for the rates that are entered by the county for their contract providers. So what that means is the process that was already in place is still there, where you can, if you want to, voluntarily provide contractor rates to DHCS that would establish a maximum rate for all your contractors that you claim for. And you'd want to take a look at DHCS Info Notice 13-07. There's a form you can fill out and tell them that these are the maximum rates that you will pay for your contract providers. Once you complete that, if you want to, because you don't have to, it will only be applied to the contractor services and not the services provided by the county. You get one rate per service function code for all the providers, so you can't go in and enter a bunch of different rates for different providers. And then when you submit a claim for one of your contractors, the amount that you receive will be based on either the lower of the claimed amount or these contractor rates that you would have established as the maximum rate. But again, that's all voluntary. If you don't provide or don't fill out that form and submit it to DHCS, they're just going to pay you based on the rates that you claim at for your contractors. So you don't have to do anything, but you can if you want. And again, the good news on this is that they're not trying to put in a different edit or an additional edit to complicate the system even more. And then we talked a little bit about the DHCS claim payment timeliness report, which is on the DHCS website. And it actually does show pretty significant improvement in terms of DHCS is now processing and paying approved claims typically within 30 to 32 days on most claims. And that definitely has been, and that's been pretty consistent over the last couple of months. And so at least you guys are hopefully getting your payments pretty quick. So are there any questions on that? Okay, moving on to the MHSA update. DHCS has asked CMHDA to form a work group to look at the revenue and expenditure report. Remember, we had quite a few issues around the revenue and expenditure report, and so DHCS has asked CMHDA to provide some input into this with a work group. And what we agreed to is that we're going to go ahead and use the cost report work group that was established several years ago to provide input to the DHCS revenue and expenditure report. There's supposed to be a meeting later this month, although I don't think we've seen anything on that. They talked about having a couple of conference calls, and I think really, one of the things we'll focus on is the relationship between the cost report and the revenue and expenditure report, and kind of the fluidness of both of those until the actual audit. So we'll see how this goes, and hopefully that will get going soon. However, the 1112 forms are still out for the revenue and expenditure report. It was due a couple of months ago, I believe. So I don't know if this work group and the work that they do will end up modifying those 1112 forms versus going forward for the 1213. So more to come on that as well. And then we talked a little bit about the Mental Health Services Oversight and Accountability Commission triage grant budget requirements. And I went ahead and just gave you one of the requirements that we've discussed has to do with they're basically limiting all non-salaries and benefit costs to 15% of your total budget. And actually, I should say all non-personnel and evaluation costs. So that there are some limits, and it's predominantly then going to fund the personnel costs of these triage personnel. The applications are due, right after the start of the new year, so hopefully most of you are aware of this. And then if you want more information, you can go to the Oversight and Accountability Commission's website, and right there on the front you'll see the Investment in Mental Health Wellness Act, RFA, and it has all the forms and requirements and everything else there. As well as if you go down a little bit further, there was they did put out a question and answer document on some of the questions that were asked regarding these grants and the applications. So if you want more information, you can go to their website. All right, anybody have any questions on either of those?
There is a question. Hold on. The triage grant doesn't allow direct costs such as travel for direct service delivery. Does the state have plans to adjust the request to account for these issues?
I think these are the final requirements, so whatever is included in that document is what they're going to apply. Now, I thought you could include those sort of things as direct costs, but they're just limited to no more than 15% of the total budget. And also included as part of that 15% would be all of your indirect costs and your county administration. So it really is a limit on how you can spend this money, or at least how you can apply for the money. Now, I guess we would assume that that's also how they're going to require you to spend the money within those budgets. But I don't. At this point, I think it's pretty firm, and given that we're sitting here, and that's what 3-4 weeks away is when the application is due. I don't think they're looking at changing it. All right.
Let me take Kimberly off mute just to make sure that she's satisfied. Hold on. Okay, Kimberly? Kimberly, did you have any follow-up questions? She wrote in the question box, this is a bias against smaller counties because our salaries are much lower, so the admin costs are much lower.
Yeah, and so I actually had an individual conversation with the OAC on this, and I explained to them how generally, your admins for small county could easily exceed the 15%, even your 87 allocation. So, but they didn't take that into account. I had actually said, well, maybe you should do 15% as a recommended amount, and then if a county can justify more, allow them to do that. But they didn't do that. They originally, if you remember, they came out and said you could only have 10%. They then upped that to 15%. But I don't, I don't think they're going to change it. But I could be wrong. So if you do have comments, I would just continue to pressure the OAC on this, because you're right. Generally, small counties have a higher percentage of administrative costs. So I'm not going to argue with you there. but again, I don't know at this point what to do, or if there's anything really to do.
She says, okay, thank you.
All right, moving on to the claims payment update. So what the state said is for anything prior to fiscal year 9-10, so fiscal year 08-09 and the prior fiscal years, if you have a question around a settlement, go ahead and contact the MHSA folks, and they'll have to research and get back to you on those on an individual basis. I know Butte had some questions, and Riverside as well, that they were working on. And then they did say that the 9-10 cost report settlement that they've received, the uploaded reconciled cost reports, and that they're in the process of preparing the settlement letters, comparing the actual amount of paid claims to what the reconciled cost report shows, and that those letters would be distributed in January, at least for the folks who have done the reconciled cost report. So that should be coming out pretty soon. And we talked a little bit about the warrant intercept process, where the program staff have met with their accounting staff. And so apparently the accounting staff that have finished reconciling the paper offsets that were prepared under DMH. I guess there were just boxes and boxes of these paper offsets that they had to go through and reconcile against whether a payment was made or an offset was made. They've done that, and now they've got the data and the ability to respond to counties if you have questions on that. So if you have questions on offsets, you should be asking, I guess, still through MedCCC. They did mention that they are looking at eliminating this manual offset process and going to a netting process against the claim amounts, but they really weren't sure about the details. So eventually there would be an information notice explaining all this to us, but at this point they're looking at eliminating the manual offset process at some point. And then they are proceeding with an electronic fund transfer process instead of issuing these paper warrants. That will allow the 835 process to get sped up, I guess, because they can post weekly warrant numbers against the claims, and so you would see the 835 process more frequently. So it would be weekly rather than monthly. So they're still working on that. And again, I don't think they gave us a time frame as in terms of when that would actually happen. So any questions on any of that? All right. If you remember, probably about 4 months ago or so, the DHCS folks asked you to provide contact email that DHCS accounting can use when they do an offset or make an adjustment to payments. I guess all but 4 counties have provided that information, and so hopefully this will help with that whole manual process, at least in the short term. We talked a little bit about the county claims reconciliation, and if you remember, this is where counties have the ability to request all their paid claims information from the state, and then it's up to the county to do the reconciliation against their records. DHCS says that they've resolved most of the issues with the missing 835 files, and that they can handle additional counties if counties want to volunteer to do this reconciliation. They now have a reconciliation database that is available to all of the DHCS staff, from the auditors, MedCC folks, and this new research unit that they created. So, you know, if you're a county that has not been able to reconcile payments, you may want to contact them and get the data and try to go through the reconciliation process, although my understanding is it is fairly time-consuming on the county to actually do the reconciliation. And then, you know, one of the standing items that we've had for a couple of years now is this whole reconciliation of the inpatient managed care offsets against your realignment, and trying to get a report that would allow you to reconcile the offsets that are posted against your realignment payments. And, you know, DHCS is looking to develop some sort of statewide database, and they're asking for input from counties as to the structure of that database. And there were a couple of things thrown out in the meeting saying, you know, identifying whether it was an acute day versus an admin day, the provider, those sorts of things. You should be able to access this data now through the fiscal intermediary, but there just aren't any you know, standardized forms or reports that allow you to easily understand the information. So if you have any input into the structure of what you'd like to see in this database or the data elements, they said to go ahead and email DHCS, email Kathy Tyler, and that's her email address there, and just put IPC on the subject line so that they know it's related to the inpatient paid claims, and hopefully this will happen at some time in the near future. I know we've been saying that for a while, so we'll see. And finally, the state reported out that all the MHP contracts have been received and processed, so that's a good thing. So everybody should have their mental health plan contract executed by now. So any questions on any of those issues?
There is a question. We requested the state add units to the claims reconciliation. Do you know if they've done that or if they will be working on that?
I have no idea. So yeah, I don't know. I don't know what they've added or even what the structure of this database looks like. So I don't know. All right, moving on to still under the claims payments, DHCS has released a couple of new information notices. One was on claim 13-20 was on claim timeliness requirements, and so That is on their website, and you can kind of see here, it just goes through, says you've got a year to submit the claim consistent with federal requirements. If it gets denied, you have 15 months total from the month of service to correct and resubmit. And so this kind of goes through that. It talks about there are erroneous claim adjudications, and that you can use delay reason code 9 if the claim is more than 15 months after the month of service, and then provides the link to the change schedule posted on the department's website. And then finally, it talks about this over 1 year claim submission when you've got a late eligibility determination, and the process to follow when you have a claim where the eligibility was determined more than a year after the service was provided. And you can submit the claim to MHSA, indicating short dual Medi-Cal over 1 year claim in the subject line. And those will be handled manually. And then they also released this other information notice, 13-21, on the denied claims appeal process. And again, basically it just describes the process. You've got 90 days to appeal, tells you where to send it, and then the state has 60 days to respond to you. And then here's the information you need to include with the appealed claim. The one concern that was raised by Los Angeles was that the state will only take this from the counties, the mental health plans, and would not accept appeals directly from providers. And Los Angeles was concerned that this puts more risk on the county to comply with the time frame, because if a contractor has not or responds like on the 89th day to the county may not be able to meet the 90-day time frame to get it submitted to the state. So anyway, that was one of the concerns raised. It was unclear whether it was more of a time issue, and the 90 days just wasn't sufficient to allow the appeals to be developed within the county, or if it was something bigger than that. And so I believe DHCS is going to work with LA to identify the concerns a little bit more, and so we'll probably hear more back at the next meeting. Because there definitely are counties with contractors where the county wants to know what the contractor's doing, and wouldn't want the contractor to go around the county to appeal the claim. Also, the relationship from the state's perspective is with the county mental health plan and not with the contractor. So that generally is why the state doesn't work with contractors. They work more with the county mental health plans. So those two info notices are now published. The state talked a little bit about the behavioral health subaccount growth from 12-13, fiscal year 12-13. So there's about 27.8 million in growth, and it sounds like DHCS is going to recommend looking at the approved claims in terms of how to distribute the growth to each individual county. That they're going to run a report in January, and from that potentially develop their recommendation on how to distribute the funds, that 27.8 million, to each individual county. And then we talked a little bit about the 13-14 behavioral health subaccount allocation percentages. They've already been distributing funds, and they gave us a schedule of the percentages by county, but there hasn't been any backup to how those were determined. And so they did say they're working on an information notice. I think we made it pretty clear that a lot of counties use that backup in terms of how to identify how much funding is for substance use disorder services versus EPSDT versus managed care. And so hopefully we'll see that information notice soon, and it will hopefully identify how those percentages were calculated and the base amounts that went into determining each of those percentages, the base amounts by program, so that for those of you who do use that information notice to identify the funding of each program, you'll have a basis for doing that. So any questions on any of that stuff? All right, moving on to the work group updates. So and we've been talking about a lot of this for a long time, and it is somewhat a slow process. But they did say they have worked through most of the issues with the fiscal state plan amendment. For those of you who aren't aware, there's really 3 sections to the fiscal state plan amendment. There's a section on the fee-for-service Medi-Cal inpatient reimbursement. There's a section on the specialty mental health inpatient reimbursement. And then there's a section on the specialty mental health rehabilitative and case management services reimbursement. So they've submitted all the specialty mental health pages to CMS informally, but they're having DHCS is having some difficulty, I guess, finishing off the fee-for-service Medi-Cal inpatient pages. They're hoping to have those done later this month and again submit that all informally to CMS for review. CMS will hopefully have their informal review done by early January, and provide feedback to the state on things they want to see in there or things that still aren't clear. Then the state will submit the official state plan amendment, hopefully shortly right after that. And then the CMS has a 90-day time frame to review the official state plan amendment. But hopefully, given all this informal work that they've done, it should be pretty easy for CMS to approve it once they've gone through all this informal dialogue with CMS. Where this really impacts us is on this whole supplemental claim process, which is for services or costs that exceeded the schedule of maximum allowances, SMAs, from January 1st, 2009 through 11/12. And it sounded like DHCS had identified had already developed some draft claim forms, but they're just waiting for the state plan amendment to get approved to release those to counties that want to go ahead and submit a claim for additional reimbursement. They said they are going to take data from the cost report and that it will be a manual claim process. I mean, hopefully it's real simple and it's like a one-page form that you fill out and request additional reimbursement. The one thing that was not real clear is what they're going to do with your published charges, and it was raised that we have concern that they're going to try to apply the lower cost or charges to these supplemental claim forms, and that if you go back to January 1st, 2009, a lot of folks were using the SMAs as their published charge or their customary charge schedule. And so if the state's going to apply that, then there really is no benefit for going through this whole process. What CMHDA has said is that we don't believe that county, especially mental health, has a customary charge given what's in the provider reimbursement manual, and so we'll continue to push for that, and especially if they do try to apply it to these supplemental claims. So we'll see what comes out of that. It may get political, but at this point we'll just have to wait and see how they how DHCS is going to interpret this. And if they do try to apply the published charge or customary charge, then we're going to have to push harder on that. Technically, you don't have a customary charge given the nature of our system. So more to come on that. Probably, March, April of next year. We talked a little bit about the CPA protocol, not a whole lot. They've received some comments from CMS, and they anticipate approval of the Certified Public Expenditure Protocol around the same time that they get approval of the Fiscal SPA. And then we talked real briefly that the Medi-Cal, especially mental health cost report for 12/13, that now the summary cost report template is posted on ITWS, and that they're the state's mainly focused now on developing the automated edit process to have that in place so that you can upload and get back your error reports when you upload, and hopefully that'll be in place soon. I don't know if anybody's submitted 12/13 yet, but I got the impression that they weren't going to be able to accept submissions and actually run the edits until maybe later this month. Anybody have any questions on any of those issues?
There is a question. I heard there was a work group for customary charge. How can we join this group?
So you can always, so there is a work group, although the work group hasn't met in probably like 7-8 months. This is an issue, this customary charge issue is something we raised, CMHDA raised with the state, and they were getting ready to issue an information notice that really didn't clarify anything. That basically just stated what's in either the provider reimbursement manual or federal regulations. So bottom line is, if you want to get on the work group, you can contact Don Kingdon at CMHDA. But again, we haven't had a meeting in quite a while. But it may, the issue obviously is still some concern to us, and so we'll probably, after the first of the year, we'll probably hopefully be revisiting it with the state. So just contact Don at CMHDA. Because and this also comes into the whole the issue of UMDAP. Do we need UMDAP? And a whole bunch of issues. But kind of the bottom line is, we don't think we have customary charges, and so therefore we shouldn't have to apply this lower of cost or charges, because the provider reimbursement manual specifies if you don't have a customary charge that you get reimbursed actual costs. So, all right, any other questions? Okay, then we talked a little bit about some of these other fiscal issues in county to county. On the LIP claims, apparently those are not being paid until your mental health claiming protocol has been approved, and I'm not sure if anybody's been approved yet. So unfortunately, those claims are not being paid. We talked a little bit about the state auditors around drug Medi-Cal, and how apparently they've been going into some counties pretty much unannounced, and even going into county drug Medi-Cal clinics, county operated clinics, and asking for things that you would typically ask for from a private entity, such as articles of incorporation, financial statements, etc. So it sounds like they're, as a result of some of the fraud issues that occurred, I believe in Southern California, it sounds like the state has kind of gone, full bore into auditing some of this stuff. So we talked a little bit about that. We talked about the behavioral health sub-account growth. If you remember, CMHDA conducted a survey of the counties, asking how much did your total specialty mental health program grow, your EPSDT, and then your drug Medi-Cal. the results of that, and from that is what CMHDA was going to use to recommend how to allocate the 12-13 growth, the 27 million. And what the survey showed, and not everybody responded to the survey, not all counties, but roughly 88 million in growth between 11-12 and 12-13 of total specialty mental health match. Of that, 43 million was related to the EPSDT program, and then there was also an $8 million growth in match for the drug Medi-Cal. So clearly, just for EPSDT and drug Medi-Cal alone, we had more growth that was reported through the survey than the 27 million that's available. So I believe what CMHDA was going to recommend is that because there's not enough growth, that the state just go ahead and distribute the 27 million based on the 12-13 behavioral health allocation percentages that existed and were used to allocate those funds in 12-13. So we'll see, how that goes and whether the state accepts that. Also, as a result of this survey, we talked a little bit about this whole Public Records Act request that was made by one of the children's advocacy groups, I believe, and they initially contacted CMHDA and asked for the data, and CMHDA agreed to provide them the aggregate figures, the figures I just mentioned to you, but didn't want to provide the individual county data for a whole host of reasons. But that wasn't sufficient for them, so they went ahead and did this Public Records Act request. And so at this point, hopefully, if you've complied, you would have just sent them the same survey form you sent on to CMHDA, and let them have it. So a couple of things. Well, hopefully CMHDA and Don will be sitting down with these folks and talking to them and basically stressing that not everybody prepared the survey in the same way, that all of these are estimated amounts, even for 11-12, and so basically that you can't really use it to go and allocate funds to a specific county. We do believe that overall it provides probably an order of magnitude in terms of the growth. So when you put everybody together, the 88 million total specialty mental health is probably about right, but to try to parse out funds or allocate funds to individual counties based on this data doesn't make sense. Also, you really can't use it because not everybody responded to the survey. So hopefully that will occur, and this will have been kind of a futile act on their part to just collect some data that is basically meaningless on an individual county by county basis. So anyway, we'll see more on that. I think we talked a little bit about the Affordable Care Act implementation. And really, this more had to do with the health plans having to implement a behavioral health benefit and actually more of a mental health benefit, and how in quite a few counties the health plan has contracted or subcontracted with another entity. Often this entity is Beacon, and then Beacon has been aggressively contacting both county operated providers as well as contract providers to try to get them into their network to provide the mental health benefit that health plans are required to have available as of January 1st. And so I think there's a lot of work going on right now in each county on looking at that and how to contract potentially. And there's a couple of ways to handle it through the cost report and the claims process. But definitely more to come on that, and we'll see how it actually goes. So, and then we talked a little bit about the California Health Facility Financing Authority grants. These are the grants for crisis beds and also mobile crisis services. And we talked a little bit about how do you sustain the services if you're using these grants to fund the services. And I think to most of our knowledge, there isn't any sort of funding that's being set aside to sustain it long term, that you would probably have to fold it into one of your MHSA programs or fund it with realignment or something else after the grant funds ran out. And then just a couple of announcements. We don't have a Financial Services Committee meeting in January. And then the Northern California Mental Health Administrators Association is holding a billing and coding training on January 14th. And there was a flyer, although I didn't get the flyer, there was a flyer that was handed out there on that billing and coding training. And one other thing, so we won't have the call, this call next month, but on February 5th, we're probably going to have a training or at least a workshop on the state budget that's released in January just for small counties, and how to look at some of the revenues and kind of give you some trends. And I don't think we're anticipating many issues in the budget, but if there are, then we would cover that. So tentatively put that on your calendar for February 5th. And again, the idea being hold that the afternoon before Financial Services Committee the next day. So to try to give you guys special, if you have special issues you want to cover regarding the state budget. And so that's pretty much it. Anybody have any questions on any of this stuff or anything else?
Doesn't look like it.
Great. All right. Well, everybody get back to their cost reports and hopefully get them finished in time to enjoy the holidays. And we'll talk to you guys next year.
Thanks, Mike.
Bye-bye.
Bye.